portion of substance abuse disorders for behavioral science and psychiatry for Falcon Physician Reviews. First of all, we're going to start talking about some stimulants. And common stimulants are going to be caffeine, nicotine, amphetamines, and cocaine. And all of these influence the central nervous system by causing increased alertness. And they all work by increasing dopamine neurotransmission. Now, we use a lot of amphetamines in our normal clinical practice, especially child psychiatrists. We use a lot for ADHD, and some adult psychiatrists and neurologists will use it for narcolepsy. And the most commonly prescribed amphetamines are dextroamphetamine, methamphetamine, and methylphenidate. But prescribed amphetamines can be drugs of abuse. And how would you know if someone was abusing one of your medications that you're giving them is, first of all, they'll call for early refills, they'll be very demanding, they'll be wanting increased dosage each single time. So it's going to be pretty obvious that someone's abusing the medications. Patients who actually are not abusing generally won't need early refills. They always have pills left over and are very satisfied with the treatment that they're getting. And of the amphetamines, especially used for ADHD, Adderall is frequently the one that's usually sold by adolescents for drugs of abuse. Other illicit amphetamines include ecstasy, ice, speed, and crystal meth. So you also have cocaine, which is another form of stimulant, and there are several different forms of cocaine such as powder, crack, and freebase, and you can use cocaine in various different forms. You can use it intranasally, you can smoke it, or you can inject it. Now, caffeine is probably one of the most common stimulants of abuse besides nicotine, and people drink caffeine all the time. We all drink it in the morning. It makes us wake up, makes us more alert. But when you get too much caffeine, you'll feel restless, nervous. If you drink it too close to bedtime, insomnia, diarrhea, which is due to increased GI motility, increase in your blood pressure and heart rate, and muscle twitching. So whenever you see an intoxication, generally you will see the opposite in withdrawal. So if you're having a hard time remembering, okay, this is intoxication, this is withdrawal, it's too much for me to remember, just remember, if you remember one, you can kind of see the difference. It'll be the exact opposite in the intoxication or withdrawal, whichever you're memorizing. So when you stop caffeine, you'll have headache, irritability, lethargy, fatigue, and you'll be much more hungry. So how will they give you a vignette of caffeine in your exam? Generally, they'll give you a younger woman who has an office desk job, who comes into you complaining of having increased anxiety, restlessness, and it'll show you all the symptoms of caffeine intoxication. And then you'll know, I wouldn't choose cocaine for her because this is a person that's working, has a job. Most likely it's going to be that she's drinking too much coffee, or nowadays, especially with all those energy drinks, is she having a little bit too much Red Bull. So caffeine would be most likely in a vignette like that. But if you have a male person who's out on the streets, who comes in with, a heightened sense of reactivity, is very alert, then, okay, you can think more of a cocaine kind of situation. Next, we'll talk about nicotine. Again, very similar symptoms to the caffeine. Increased alertness, it's an improvement in your mood, it decreases your appetite, increase in your blood pressure and heart rate, increase in GI activity, and if you withdraw from it, you'll have headache, irritability, fatigue, and increased appetite and craving. So how do you treat nicotine dependence? Smoking cessation groups are very helpful, but usually aren't helpful just by themselves. And what's usually most helpful is that if you can use a nicotine patch or gum along with an oral medication such as bupropion, which is called Zyban or Wellbutrin, these two in combination can really help decrease smoking. Again, remember, smoking is the leading cause of death in the United States, so if you have an answer that has smoking in it, most likely that's going to be the right answer. Next, we're going to talk about cocaine and amphetamine. So what cocaine does is that it blocks the reuptake of dopamine, and amphetamines cause the release of dopamine. So by cocaine blocking the reuptake of dopamine, it's increasing the amount of dopamine in the synaptic cleft, and amphetamine is causing the release of dopamine from the presynaptic cleft into the synaptic cleft, therefore increasing the concentration of dopamine. So how does cocaine and amphetamine work? We had talked earlier about the dopamine reward pathway. Well, this is exactly how they will work. They will go to your nucleus accumbens and they will cause you to feel good, and it'll make you want to use the medication over and over again. So what does cocaine or amphetamine intoxication look like? You have an elevated mood, increased energy, you don't need to sleep, you don't need to eat, you might be more irritable and aggressive, and frequently patients with cocaine and amphetamine will become very psychotic and paranoid. And if you look at the physiological components of intoxication, they will have vasoconstriction, vasospasm, elevated blood pressure, arrhythmias, and pupillary dilatation. Now, it is very important for you to remember that pupillary dilatation is found in cocaine and amphetamine intoxication, because on your exam they will give you lots of pupillary signs for cocaine, amphetamine, and opiates especially, and they'll want to know if it is the intoxication phase or if it is the withdrawal phase. So what does withdrawal of cocaine look like, or withdrawal of amphetamine look like? Well, if you are really revved up and excited in your intoxication, then withdrawal will be the exact opposite. You'll sleep more, you'll eat more, you'll be tired, you'll be depressed, and you'll also have pupil constriction with withdrawal. Whereas with intoxication, you had pupillary dilatation. So what are the effects of cocaine on the fetus and child? It can cause fetal hypoxia and placental abruption. And this is a very important point for you to remember for your exam. Left ventricular hypertrophy, reduced head circumference, decreased birth weight, irritability, hyperactivity, and attention problems. Medical complications of cocaine. If you have a patient on your exam who's 33 years old, in the 30s, very young, and has a myocardial infarction, think likely of a drug disorder. There can also be other reasons for this, but you really want to make sure you get a urine drug screen and make sure that this person is not using some kind of cocaine or amphetamine. Also look for elevated blood pressure, pulse, arrhythmias. It can cause central nervous system abnormalities such as strokes, respiratory problems such as hemoptysis, cough, and chest pain. And other problems it can cause is nasal septum necrosis. What happens is that a lot of people use cocaine intranasally, and what it does is it causes vasoconstriction of these blood vessels, and there's not enough blood going to your nasal septum, and it causes the bridge of your nose to collapse if you use it for continued use. Malnutrition. If you use it IV, there's an increased risk of getting hepatitis B, C, and HIV. Endocarditis is a problem, especially if you're sharing needles and you have bacterial infections. Pulmonary emboli and intestinal ischemia are also other problems. So how do you treat cocaine use? There's really no medication that's very helpful for treating intoxication, withdrawal, or maintenance of cocaine. So you have to either do some kind of therapy such as cognitive behavioral therapy, a reward system, and self-help groups are generally very helpful. Next, we're going to talk about inhalants. And on your exam, inhalants are frequently used by teenagers. You won't generally see adults using inhalants. So if they give you a vignette about this, this will probably be a 15, 16-year-old or kids on a school bus. And what are some examples of inhalants? There's solvents, paint thinners, glue, and gas. And these are people that are sniffing these things. So they are smelling these items and getting high. And what will they look like? They will have altered consciousness, confusion, nystagmus, ataxia, delirium. They can have liver problems with long-term use and dementia with long-term use. Inhalants are a very, very serious drug and can really fry your brain if you use it for long-term use. Next, we have opioids, which are very high yield for your exam. And opium comes from poppy seeds. And usually where patients get opioids from are because we use them to treat pain. And they also get them from the streets, such as heroin, which is a commonly abused substance. And generally, patients have to go through alcohol, marijuana, cocaine, and finally they get to heroin. So if you're a heroin-dependent person, that means you're a pretty hardcore substance abuser or dependent. And they like to use heroin much more than they like to use pain pills because they're much more stronger and they cross the blood-brain barrier much more quickly. Opioids going to bind to different receptors, specifically though and primarily to the mu receptor in the brain. So what does opioid intoxication look like? Initially you will feel some euphoria and then followed by some analgesia, sedation, respiratory depression in high doses, and meiosis. Very important, opioid intoxication causes constriction of your pupils. You also get slowed down bowel movement, so you'll have constipation, peripheral vasodilation, and hypotension. So generally with opioids, things generally slow down, whereas with intoxication of cocaine and amphetamines, you're very revved up. How do you treat an acute intoxication? Well, if they have respiratory depression, then you might have to put them on a ventilator, just basic supportive care. You can also give them naloxone, which is a short-acting opioid antagonist. And say if a patient has poor respiratory drive, their blood pressure is out of whack, and they have constricted pupils and they're in a coma, then you can give them naloxone and they should immediately be awake again. So what is opioid withdrawal? It usually occurs about 8 to 10 hours after discontinuation, and this is not a serious withdrawal. You will not die from opioid withdrawal, but you will feel very, very uncomfortable. And they will be very irritable, they will have nausea, vomiting, diarrhea, they will have body pains, they will be crying more or just have more lacrimation. And remember, on opioid withdrawal, you have pupillary dilatation, they'll be yawning, goosebumps, fever. So to remember opioid withdrawal, remember flu-like symptoms. So these are patients that hurt all over, they have nausea, vomiting, and their body hurts, and they have a fever, and they don't sleep well. So if you can remember flu-like symptoms, then you can remember opioid withdrawal. So what can help you identify that this patient might be using some intravenous drugs or using some opioids? Well, they'll have needle marks and tracks. They'll have multiple tattoos to try to hide their tracks. They'll have thrombophlebitis, which is inflammation of their veins, abscesses and ulcers, and piloerection. Now, piloerection will be present when they are withdrawing from the opioids. And you might also see some liver problems, such as jaundice, and this is because they have hepatitis because they're sharing needles. So how do you treat opioid withdrawal? Again, this is not a life-threatening illness, but if the patient is uncomfortable, you want to help them through it. So frequently in withdrawal, you'll notice some elevated blood pressure. You can help that with some clonidine. You'll also notice some increased sympathetic action. If you give them some clonidine, it will help the noradrenergic hyperactivity. You can give them clonidine with naltrexone. Naltrexone is a longer-acting opioid antagonist, and it just shortens the time for their detox. It makes it so that they're not as uncomfortable as long. Once they've completed their detox, you can also give them methadone, which helps with their withdrawal symptoms, and it doesn't produce the euphoria that you get from using heroin, so you can actually use it also for long-term treatment of heroin addiction. Buprenorphine is a partial mu agonist, which blocks the withdrawal effects and doesn't cause euphoria. And you can also give them symptomatic treatments, like if they're having muscle pains, give them a pain reliever. If they're having diarrhea, give them an antidiarrheal medication. So again, the main treatment of opioid withdrawal will be very supportive care. It's not life-threatening. So how do you treat opioid dependence? Frequently, patients are maintained on methadone for long periods of time. It really depends on who's giving it. Some people feel that you're switching the addiction from heroin to methadone, but they have noticed that if you put a patient on methadone maintenance, it actually decreases violence. And that is because the patient's not having the severe cravings for the drugs, and they're not trying to find illegal ways to find the drugs, such as stealing and murdering. So in some ways, methadone maintenance can be helpful. You can also use L-alpha-acetylmethadol, or LAM, which is also an opioid antagonist, which is longer acting than methadone. You don't have to give that on a daily basis. They can actually only take it about 3 to 4 times a week. Then you have buprenorphine, which is another partial opioid agonist, and this is also very helpful in the fact that it has a ceiling effect. So even if patients take large amounts of it, they can't get high and they can't get overdosed with it. Then you have naltrexone, which is an opioid antagonist, which can also be helpful. And psychotherapy such as CBT, supportive therapy, family group, and self-help groups can also be very helpful. Next, we're going to talk about some hallucinogens such as LSD, magic mushrooms, mescaline, ecstasy, marijuana, hashish, ketamine, and PCP. So how do these medications work? Generally, they increase the availability of serotonin, especially LSD. And what does it look like when you get intoxicated? You have dilated pupils, an increased heart rate, initial apprehension and mild anxiety, But then you have a very labile mood from euphoric to depressed, distortions of thought and perception, depersonalization, and you can have flashbacks years later. Also, these patients are highly agitated. So with PCP, what it'll look like is you'll have nystagmus. And PCP is one of the very few disorders or a few drugs that will actually cause you to have vertical nystagmus. So if you see on your exam anywhere vertical nystagmus, then quickly think PCP. Also, you'll have ataxia, dysarthria, muscle rigidity, hypersalivation. You'll be psychotic and very, very hostile. So what you'll see on your vignette will be a patient who comes into the emergency room and he requires 10 policemen to hold him down. He's very, very agitated. And what the treatment for PCP is to put them in a quiet, dark room. Don't give them too much stimulation. You might want to use some sedative medication to help keep them calm, but you don't want to excessively agitate this patient because it only makes it worse. Our next drug is ecstasy, and a buzzword for you on your exam is going to be rave parties, and this is the drug of choice at rave parties. And another important point that you will notice on your vignettes is that it can disrupt the body's ability to thermoregulate. So these patients will frequently come in with elevated body temperatures. Again, when you use ecstasy, you can also have some psychotic behaviors, and it can lead to memory loss and Parkinson's disease if you use it for prolonged use. Another very high yield question on your exam will be about cannabis or marijuana, and it is also known as tetrahydrocannabinol as the active compound. And what does it look like when you get intoxicated with marijuana? Immediately you'll notice the very red eyes. You'll initially be very euphoric and happy. It'll cause an increased appetite. So these people are frequently snacking, dry mouth, distortion of time and space. So they feel like things are moving much slower than they really are. And sometimes people will get paranoid, not always. How do you treat marijuana? You basically give them acute and supportive treatment and just reassurance. There's no medications that will help any kind of acute intoxication with marijuana. Now, with long-term use of marijuana, a problem that you can get is chronic amotivational syndrome. So these people are very apathetic, they don't want to do anything, they just want to stay home, they won't go to school, get an education. So the long-term problems with marijuana can be amotivational syndrome. Again, what is the treatment for patients who are intoxicated with hallucinogens? Make sure that you reassure them, especially because they're very suggestible and they're in a hallucinogenic state. Treat them with a low stimulation environment, and use an antipsychotic or a benzodiazepine if you need to calm them down. So how will you be able to detect these substances? Well, you can detect the substances for a particular amount of time in their urine. So if a patient comes in to you and says, "Doc, I haven't been using cocaine for months," and his urine drug screen comes up positive for cocaine, well, he's lying, because there's no way that months ago he could have used cocaine and it's now showing up in his urine. Generally, cocaine only stays in your system for 2 to 4 days. Other important ones to know is that if you use very heavy marijuana, then it can actually stay in your system for up to a month. Alcohol is very short-lived, only found for about 3 to 10 hours. Methadone, 2 to 3 days. Heroin as well, 1 to 2 days. Amphetamines are also only found for 1 to 3 days. So here are some high yield points for you on your exam, which is the pupil finds in the emergency room. So if you have intoxication and there are large pupils, there's pupillar dilatation, remember cocaine and amphetamines are your major ones, followed by LSD. And if it's on a withdrawal state, then it'll be opiates and alcohol. And how will you be able to correlate these? You'll have to look at the pupil signs as well as the other signs of intoxication or withdrawal. Now, if you have small pupils on intoxication, that's going to be your opiates. And if you have small pupils on withdrawal, that's going to be your cocaine and amphetamines. Next, we have steroids. And we once thought they were only taken by professional athletes, but actually it's becoming more and more common even among junior high and high school kids. So what will you notice actually in a patient that's taking steroids, and how they'll show you this on your vignette, will be a pretty normal functioning teenager who's been doing well in school. He's an athlete, he's on the track team, he's on the football team, but just lately parents have noticed that he's become much more aggressive and irritable, and he has thoughts of depression at times and even talked about suicide, and all of a sudden he has these sudden mental status changes. Also, they'll notice that the patient has more acne, and in men you might notice some breast development, some premature hair loss. In women, they might have some hirsutism, which is a male pattern facial and body hair, clitoromegaly, and deepening voice. So you automatically want to start thinking about, well, are they using some kind of performance-enhancing medications? And now we're going to talk about key principles of rehab. So first thing you want to do is you want to detox the patient from whatever substances that they're doing. And you really can't start rehab principles if a patient is very uncomfortable, if they're having a lot of physical symptoms. So you first want to detox them, make them as comfortable as they can be, and then you can go from there. Next, you'll go into the behavioral modifications, such as doing abstinence, rewards, discipline. A lot of people will have probation officers, employment problems, so this is usually a motivation for them to stay off the drugs. Also, random drug tests and penalties are also good ways for them to prevent using drugs, because they know that if they are found with a positive drug screen, then they will lose their job, or if they have a probation officer, will have to go back to jail. Again, you want to remove them from their environment. You want to take them away from the friends they used to hang out with, from the neighborhood they used to hang out with. It's because that's where the drugs are, and they can really have bad cravings, and if they have a moment of weakness, they can go back and start using the drugs again. And you want to look for any psychological problems. If a patient has depression or anxiety or any other psychological reasons for using these drugs, you want to get down to the root of these problems. Treat their depression, treat their anxiety, help them get into some self-help groups, and also get their family members involved. This concludes our section of substance abuse disorders for behavioral science and psychiatry for Falcon Physician Reviews.